Now we are beginning the first talk of today's section. It's our pleasure to invite Dr. Yupeng Zhang, a project assistant investigator at the Institute of Population Health Science from the National Health Research Institute in Taiwan to talk about the development of a logic model-based evaluability assessment scale for public health programs in Taiwan. Let's welcome Dr. Zhang.
Good morning, everyone. I'm Non-Communicable. I'm from the NHRI, and I'm a health policy analyst. Because of this job, I have some experience with government agencies to evaluate public health program. Government usually provide program documents and administrative data, and hope that we can use this data to show or to prove their program are effective. However, these data are not always sufficient to support that conclusion. So today, I would like to introduce a tool that we developed to address this question. It helps us to understand what we can learn from the available data and what is still missing. So the topic today is evaluating a practical evaluability assessment tool for public health program. So just consider the scenario that may be familiar to many of us. Imagine that you are responsible for a national health promotion program. This program has been operating for more than 10 years. Every year, thousands of people receive services, and many annual reports being produced. One day, the government asked the question, does this program actually improve health? And should we continue expand it or suspend it? We'll try to answer this question, and we are looking at a lot of program documents, and you see the program report, and find a lot of information about how many services delivered, how many people reached. But you still cannot answer this question with confidence. This is because before answer this question, we need to answer a more basic question. Is this program ready for outcome evaluation? This is the question that evaluability assessment, or EA, help us to answer. So the scenario just shows that having a lot of data does not necessarily means the program is ready for outcome evaluation. Annual report and the administrative data usually describe part program implementation, like input, activity, and output. They are useful for monitoring implementation, but some important information is still missing. A credible outcome evaluation requires clear outcome target, appropriate indicator, a good evaluation design, a suitable data for comparison, and a possible link between program activities and health outcomes. So the EA can help identify the gap between the evidence currently available and the evidence needed for future evaluation. So what is EA? EA is a systematic low-cost pre-evaluation process. It examines whether programs defined, implemented, documented well enough to support a useful, credible evaluation. There are two functions of EA. The first is program improvement. EA can identify gaps in program logic, implementation, indicator, and data before full evaluation begins. Second, It helps decision maker to decide whether the full outcome evaluation is feasible, useful, and justified. EA and the outcome evaluation ask two different questions. Outcome evaluation asks, did the program work? And the EA asks another question, can we evaluate the program meaningfully? In this sense, EA is not a pass-or-fail test. It is a way to support learning, improvement, and better evaluation decision. Taiwan has operated national oral health program for 2 decades. This includes preventive oral health service for children, such as fluoride varnish, facial sealant, fluoride mouth rinsing program. Our program provides dental service for people living in remote areas and indigenous communities. Government agencies need to know whether this program improves health and whether they should continue. However, a full outcome evaluation requires considerable time, money, and expertise in the data. So we need a simple way to identify whether the program is ready for evaluation and what information is still missing. We therefore developed a concise and practical tool that could use the routine program document and require little evaluation expertise. So we developed a tool based on logic model. The logic model can identify the key elements of the program, including context, input, activity, outputs, and outcomes. We then use these elements to program into the practical question that we answer using the routine program documents. We also drew on several existing EA tools, including the program evaluation assessment checklist developed by the Penn State University, a guidance from the UNICEF Evaluation Office, and a framework developed by Spain's Institute for Evaluation Public Policies. The draft was reviewed by our research team, government staff, and a panel of external experts. So, our EA tools contain 22 items across 4 domains. Domain A sets program goals and objectives. Domain B focuses on design and implementation. Domain C looks at the program outcomes, and the domain D provides an overall assessment. So, let me quickly show you what the EA tool looks like. Okay, so on the left side is the EA tools in the original Chinese version, and I translate to English version by ChatGPT. So this is the domain A. It contains 5 items. So the domain A asks whether a program has a clear evidence-based goals and measurable outcomes. Domain B looks at the program logic, implementation procedures, the equity, guidance materials, and the staff training. It also looks at target population, stakeholder engagement, external risk, and the process evaluation. So this is domain C. Okay, it's focused on outcome evidence, including the goal attainment, the program attribution, and the economical evaluation, and the equity result. So finally, domain B asks, what should be improved? Whether for outcome evaluation is needed and what data is still missing. So let's go back. Okay. So for most items, we use 3 ratings. Meets the item statements, partially meets, or doesn't meet it. And we added a short explanation or comments for each item. The purpose is not to, is to identify actionable improvement rather than calculate a score. So the EA tool can be used across the program cycle, but not all domains are used at every stage. In the planning stage, we only use domain A and domain B. The same principle applies in the implementation stage, but we can update domain A and domain B if early evidence is available. At the completion of a program, all 4 domains can be applied. We mainly use the existing program documents, including program proposal, implementation guidance, the interim or final reports, and the administrative data and the our research data. The assessment can be updated throughout the program cycle as new evidence becomes available. So we apply the EA tool to 2 overall health programs, a school-based fluoride mouth rinsing program and an indigenous overall health education program. Both programs have strengths. The fluoride program was evidence-based, had measurable target, and the document its delivery process in detail. The indigenous program is a clear goal, explicit logic model, standardized guidance, the staff training, stakeholder engagement, and the program itself is equity focused. However, in both cases, most evidence describe the implementation and process indicator. Their follow-up data was limited. Comparison data was unavailable, and the economic evaluation was not included. So we identified 3 information gaps for future evaluation, including outcome measurement over time, the design for program attribution, and economical evaluation. So what does the EA add to the usual review process? First, it separates service delivered from a health outcome. More services does not automatically mean better health. Second, it made the program logic more visible by asking how activity linked to outcomes. Third, it identified missing indicator and data before we invest too much time and resources in the full outcome evaluation. Finally, it integrates equity concern into program design and outcome assessment. EA therefore provides a quick, structured way to diagnose a program, identify evidence gaps, and guide the future improvement and the evaluation. So here are conclusions. First, a short checklist is more practical for routine document use. However, rating alone are not enough. Narrative description of a program's strengths and weaknesses are also important. Second, collaborative review involving evaluators, program managers, and stakeholders can turn the identified weaknesses into actionable improvement. The tool also has some limitations. First, it depends on available program documents, and this program document documents may not fully reflect actual implementation. In addition, EA does not establish program effectiveness or causal effect. A favorable EA result does not mean that the program is effective, but it is better prepared for future outcome evaluation. So our next step is to apply this to a more public health program and to develop the practical examples and user guidance. So there are three take-home messages. A program can be active and productive without being ready for critical outcome evaluation. EA can identify weakness in program logic, implementation, indicator, and the data before we carry out a full evaluation. Third, EA should support learning improvement, not only for judging or ranking. So this is my presentation. Thank you.
Thank you so much, Dr. Chang, for your very useful and insightful presentation.